Hi, today we're going to cover addictions, and this will be a bit longer than 5 minutes. Again, bear with me, but we have a lot to cover. So let me break down addictions in this way. Why don't we break down substances into uppers, that is cocaine, amphetamines, and caffeine. For caffeine, all you really need to know is they can cause anxiety, insomnia, and they can cause Saturday headaches. Caffeine withdrawal causes headaches. People don't use as much caffeine on a Saturday as during the week. They can get a headache. Saturday headaches, the test question answer is caffeine withdrawal. Then downers, benzodiazepines, alcohol are barbiturates. And fortunately, these days, many people don't abuse barbiturates because they have a problematic LD50. There's not much difference between therapeutic dose and the lethal dose. Then there are others, uppers, downers, others. Others are opiates and the psychotomimetic drugs, PCP and LSD, and marijuana. Now, the reason why I didn't include opiates into downers is nobody's ever died of opiate withdrawal. What do we need to know about these things? We need to know intoxication symptoms and withdrawal symptoms. So if you break it down into a chart, we can understand things. And you say this may be complicated, but here's the deal. Intoxication symptoms are the opposite of withdrawal symptoms. And, of course, uppers are the opposite of downers. So if you know one block, you know all the rest, because this will be opposite, this will be the same, and this will be the same as well. So in other words, if you know one, then you know the other one. Next question, what do you need to know about intoxication and withdrawal of these substances? Well, you're going to need to know cardiovascular symptoms, neurologic symptoms, and psychiatric symptoms. So what happens on upper intoxication? What does this do to your brain or to your body? Cardiovascularly, if you are revved up, your blood pressure goes up, your heart rate goes up, and your risk of cardiac rhythm problems goes up. What happens to you neurologically if your brain is revved up? You have an increased risk of seizures. What happens to you psychiatrically if your brain is revved up? You can get anxious or agitated or psychotic. Now, I don't mean to suggest they're on a continuum, though Freud believed they were. Now, what's the opposite of this? What happens on withdrawal? Cardiovascularly, not much. Neurologically, you have decreased seizures, but nobody really worries if you're not seizing. What's the opposite of agitation psychiatrically is lethargy. So what does somebody addicted to cocaine do on withdrawal? They use more cocaine. And that's what leads to the binge cycle of cocaine or amphetamines. Okay, now what happens on intoxication of downers, benzos, or alcohol? What happens to you cardiovascularly is not much. But you should always check a pulse ox for somebody coming in using alcohol or benzodiazepines. What happens to you neurologically? Again, decreased seizures, that's how they're used. Psychiatrically, lethargy. What happens to you when you are withdrawing from alcohol or benzodiazepines? Cardiovascularly, your blood pressure goes up, your heart rate goes up, your risk of rhythm disturbance goes up. Neurologically, you seize or can seize. Psychiatrically, you can get anxious or agitated, and you can become psychotic. So what is the most dangerous? Upper intoxication or downer withdrawal. Now, the reason why I did not include opiates here is nobody's ever died of opiate withdrawal. But if you were to say, come on, it's the same, an argument can be made for that. Okay, now, how do we treat this? How do we treat upper intoxication? Cardiovascularly, how do you treat increased heart rate, increased blood pressure? Clonidine is a good bet. Beta blockers are not wrong, but you can have unopposed alpha action. So clonidine is a good answer. What happens if you're seizing? Benzodiazepines. What happens if you're anxious? Benzodiazepines. What if you're psychotic? An antipsychotic. So that can be useful. And if somebody is real agitated in either upper intoxication or downer withdrawal, it's not unusual to use both benzodiazepines and haloperidol. Remember that haloperidol or antipsychotics will lower the seizure threshold. So generally people use them either when someone is psychotic or extremely agitated. Okay, so what happens on upper Withdrawal, there's not a lot to do, which is why, again, cocaine addicts usually use more cocaine, and that leads to the binge. Downer, intoxication. Remember to check the pulse ox. Downer, withdrawal. Clonidine, benzodiazepines for seizures, benzodiazepines for anxiety, and antipsychotics if they're psychotic. Now, how would you treat somebody who's psychotic from a hallucinogen, from PCP or LSD? If they're psychotic, use an antipsychotic. And again, you can use benzodiazepines, and sometimes you can use them both together. Some people call it B52, 5 of Ativan, 5 of Haldol, 2 of Ativan, and you can put it in the same syringe for a healthy young adult. Okay, now, how do you treat the disorder? We've talked about intoxication and withdrawal. How do you treat the disorder? You treat the disorder by using medication-assisted treatment for opiates and for alcohol. For opiates, you have choices of an opiate agonist, methadone, a partial agonist, buprenorphine, which in combination with naloxone is Suboxone, as you know, and then naltrexone, and that is best given intramuscularly. Vivitrol shots monthly can be given, and of course you know that there are shots Sublocade for longer acting Suboxone or longer acting buprenorphine. So for alcohol use disorder, there are choices naltrexone, topiramate, and also gabapentin. Most people believe that naltrexone and topiramate are better treatment options. Gabapentin, however, is becoming popular for outpatient treatment of alcohol withdrawal. If somebody comes into your office on only alcohol and they don't need to be admitted, gabapentin is a safe treatment option. How do you do it? 1,200 milligrams the first day, 1,200 the second day, then 900, 900, next day 600, 600, next day 300, 300, which will give you a little more than a week coverage. If somebody finds it very helpful, you can just give them 1,200 and more. Gabapentin works better in alcohol withdrawal the higher the dose. 1,800 works better than 1,200. Okay, finally, what is the psychotherapy for substance use disorders? The psychotherapy for substance use disorders is motivational interviewing. Motivational interviewing is not, come on, you can do it, but rather motivational interviewing explores the patient's motivation for using substances. So you can ask, why do you do this? What's in it for you? What does the substance do for you? And what does the substance do to you? What cost has it given you? And then you can get an idea of where that balance is for the patient. Find out where you agree, go downhill, and pursue areas where you agree, reiterating that for the patient and going on from there. Okay, so this is a bit longer than 5 minutes. I apologize, but as always, I hope that you will read more. There's a lot more to know. Thank you.